So Mark, about 6 months ago, you injected this perp thing into my shoulder.
Yeah, I think you're talking about PRP probably.
Oh, is it not perp?
Yeah, so in the business we refer to it as Platelet Rich Plasma.
Oh, that's what it stands for.
So yeah.
Hey there, I'm Mike.
And I'm Matt.
And I'm Jody. The Wild Health Podcast is our quest into human performance, longevity, and personalized medicine. Together, along with experts in these fields, we'll learn how to live longer, better, and become smarter and stronger. We'll do the deep dive into the research and hard work of putting it all together, and you reap the benefits.
But we injected your shoulder about 6 months ago now. I think you don't mind me talking about your shoulder a little bit.
Yeah, talk about my shoulder.
Yeah, so we saw you for your shoulder, and you had a pretty decent sized rotator cuff tear, almost full thickness, and some symptoms associated with that just weren't really getting better with some rest and physical therapy and the usual stuff that we try for those. So, when we talked, you weren't all that excited about undergoing another rotator cuff repair surgery and the time and rehab and post-operative kind of pain that was involved with that. So we were looking for other options, and I've had some good success with doing PRP for these in the past. So that's where we settled out.
Yeah, Mark, you had just mentioned it, but I had, just before you did this PRP injection on me, had a rotator cuff surgery on the opposite shoulder, 6 months before or something ridiculous like that. So this was a really fresh in my mind how terrible that rotator cuff surgery was. And I was really interested in a non-surgical intervention. And it turns out that I actually have a SNP in my collagen 1A1 gene that puts me at higher risk for tendon injury. So not really that unreasonable that I had another injury so soon after my first one.
Oh man, it was super sad. I was crying for you when we realized that you had that other shoulder that was torn after watching you go through the rehab after your surgery.
Well, I mean, yeah, and I was not about to immediately have surgery again. Like, that just sounded terrible. So we were talking about other options, and I remember I asked you about just like doing a steroid injection, and you told me that was a bad idea. Can you expand on that a little bit before we get into this perp thing?
Okay, before Dr. Goodman expands, who exactly is Dr. Mark Goodman? Well, the best explanation would be miracle worker. If he can get Mike to quit whining about a stinking shoulder, then I consider him a miracle worker. Holy cow, that guy is as whiny as he is smart. More specifically, though, Dr. Goodman is our Wild Health Director of Sports Medicine. We've been working with and teaching with Mark for years now, and he's a brilliant doctor, a workout monster, and all-around great guy who's amazing at getting athletes back to their peak after injuries.
Sure. Yeah. So I think steroids definitely have a role in orthopedics, and they can be used successfully to facilitate rehabilitation, especially in someone with a partial thickness cuff tear who has some symptoms of impingement. In your case, I was just a little bit resistant to do that with looking at your ultrasound and seeing that you just had that one whiff of tendon that remained intact. And we know that over time, steroids are probably not good for tendon and for cartilage. And there's been a couple studies that have come out recently. The most recent one was back in 2017 in JAMA, where they actually looked at patients with knee arthritis and followed them out for 2 years and showed that patients that were getting triamcinolone injections, which is a steroid we commonly use in knee injections, had some significantly decreased cartilage volume compared to those who just got intra-articular saline. So a steroid injection isn't a benign intervention, and there's also some associated risk to that as far as endocrine dysfunction, hypertension, can make your blood sugar go high, can lead to decreased bone density. So, in the right person at the right time, it can be helpful. But, in someone who's younger, I'm trying to steer them kind of away from doing a steroid initially, and the risk that we're going to kind of decrease their ability of their tendon to heal and maybe potentially increase their exposure to one of those risks of the bad side effects. So I think that's where regenerative medicine comes into play.
Awesome. So let's get into it. And it occurs to me that maybe I should tell everybody who you are. So Mark Goodman, we've got here today on the podcast. Welcome to Wild Health, Mark.
Hey, thanks. Thanks for having me.
Mark's a good buddy, and I work clinically with Mark in precision medicine business as well as in emergency medicine. And Mark is a sports medicine doc. So he's got you work 3 different jobs or something like that?
Got a few different jobs, yeah.
So Mark works quite a bit in lots of different areas, but one area that's super interesting to me is this idea of sports medicine, and he's specifically been using PRP or platelet rich plasma for some time. So we wanted to have him on the podcast today to talk a little bit about treatment, which is not something that we talk about all the time. We talk a good bit about preventative medicine, but there's also a realm of treatment medicine that we need to get into. And I think PRP is a great place to start with that because it's applicable to so many patients potentially. But let's start with, what is PRP, Mark?
So PRP stands for Platelet Rich Plasma. And I think this is an area of orthopedics and sports medicine that's been really growing rapidly over the last couple of years. And we refer to this as regenerative medicine. There's a lot of things that kind of fall under this umbrella. There's all sorts of new stuff coming out. And the general idea behind these type of treatments is that, your body is designed to heal injury. It's designed to get better on its own. And instead of maybe suppressing that inflammatory and healing response, maybe we can do some things to enhance that. And I think this actually plays in really well with the precision medicine side of your podcast and what you and Matt have been doing, because when we look at injuries and people that have degenerative conditions and musculoskeletal conditions, not all those are the same. And people's, not only their pathology and their kind of response to treatment is different, but also their demands are different and their expectations are different as well. And so, a one size fits all kind of approach probably doesn't fit everyone. And that's where I think some of these new regenerative treatments come into play.
So what do you mean by regenerative treatments? Is that different than injecting something like a steroid or something like that into a joint?
Sure. Yeah. So, we've used steroids for a long time in orthopedics and sports medicine, and there's certainly a role for those. But the more we learn about the pathophysiology behind especially tendon pain and chronic tendon injury, we're learning more and more that there's probably a period initially where you have some kind of injury, whether that's, small or whether you have a serious injury. But then as time goes on, the inflammation that's associated with that acute injury starts to actually settle down. And what you're left with is this process of disordered healing. So that tendon has tried to heal itself, but those collagen fibers have laid down in kind of an abnormal pattern. And because of that, you get into the cycle of repetitive kind of micro trauma, tearing that leads to chronic pain over time. And so we used to refer to all these as tendonitis, and people have probably heard of that. And more we're starting to classify these long-standing tendon issues as being more of a tendinopathy. And the itis usually refers to something that's inflammatory. And we're learning more and more that over time, there's really less of an inflammatory component that goes along with these. So when you take a kind of a biopsy of someone's tendon with some of these chronic tendon pain and issues, you really don't see a lot of inflammatory cells in there. And that makes us rethink how we've been going about treating these patients. So, typically we've done things like steroid injections or non-steroidals that limit inflammation. And that's what we're focusing on, is inflammation. But more and more we think that the inflammatory aspect of this is actually fairly minimal this far out. And instead of focusing on inflammation and reducing inflammation, we need to focus on this disordered healing. And I think that's where PRP and some of the treatments like that come into play, because we can hopefully restart that healing process and get someone's body to heal itself with a little bit of help.
And that's where platelet rich plasma comes in, right? Like you're actually taking the patient's own plasma, focusing in on the platelets and injecting that into the space to try to improve healing, correct?
Yeah, exactly. So when you get a cut or an injury, the body responds by having the platelets aggregate in that area. So let's say you cut your hand or your finger and you get a scab on that area. Well, the platelets are what forms that fibrin clot, and those platelets carry with them a lot of cytokines and growth factors in these alpha granules. And when they form, they release all of those, which sends signals to other cells in the area, but also up and down regulates gene expression to get your body to heal. So that's why you can heal that kind of cut on your finger that you got over a period of time. So we're trying to recreate that process, but in a very localized area, using a precision approach, typically with ultrasound, to put that medicine or the platelets, in this case, exactly where it needs to be.
So can you explain to me exactly what it is about platelet-rich plasma that we think helps with this?
Sure. So platelet-rich plasma has been around for a long time, and people have been using this since the 1970s in dental surgery and cardiothoracic surgery. And recently it's expanded over the last 20 years or so. And what we think causes the healing response to the platelets is these alpha granules, but also the factors that are carried within those. So there's all sorts like platelet-derived growth factor, TGF beta 1, VEGF, and these can cause a cellular signaling that can tell the body to proliferate the tendon cells and repair that area of injury. And so that's what we're trying to do, is kind of recreate that injury response initially to get that collagen to lay down and new fibers to form to heal whatever injury we're treating.
So that's interesting to me. When you did this to my shoulder, I actually had, I was actually in the middle of a fast. So I was doing like a 5-day fasting mimicking diet at the time, just kind of playing around with it actually for the first time. And is that might have actually been a bad thing then, because theoretically we want to be in more of an anabolic state if we're trying to increase these growth factors. Like if you want IGF floating around in your plasma, if you want VEGF, things like that, then a catabolic state is probably not the right setting to extract these growth factors. I mean, I know that's speculative, but does that make sense physiologically?
Yeah, that could be true, and I'm not sure of any data that really supports that either way. We know that some of the cells that we get with the PRP, we've begin to focus more kind of on the monocyte as being one of the main cells that we're looking for signaling. And when you process PRP, you're really intentionally trying to hopefully separate out platelets, but also get different concentrations of neutrophils, which can be used for different applications. And when you look at the neutrophils and the white cells, the monocyte is one of those that we think can really help with that catabolic response. The anabolic response can signal the platelet to release cytokines and promote growth. And so we really want to avoid a whole lot of the neutrophils in general, which can be catabolic and pro-inflammatory. So it's a matter of trying to separate those out, which is at this point still kind of a indirect science. So we're trying to do our best to separate those out by centrifuging the blood and getting the platelets and monocytes, leaving neutrophils behind potentially. There is some more role for neutrophils depending on what exactly we're treating. So in tendon injury, there might be a role for a neutrophil-rich PRP, which could be different than if we're treating something like osteoarthritis, where we really want to limit that inflammatory response and where we'd use a neutrophil-poor PRP. So again, it depends on the patient and what you're treating with what you're going to process your PRP like.
So are you actually processing your PRP differently based on the whatever you're trying to treat?
Exactly. So we have a system where we can select a neutrophil-rich or leukocyte-rich or leukocyte-poor PRP, and we can spin the platelets down accordingly based on a protocol to hopefully maximize what we're trying to do.
So give me some examples. If you were trying to treat like tendinopathy versus like a tendon tear, how would you choose high lymphocyte or low lymphocyte?
Yeah, so leukocyte-rich has been shown to be helpful in tendon injury. And the thought is that those neutrophils can actually release some inflammatory mediators that can cause necrosis and inflammatory response and potentially be catabolic. So maybe it actually signals the cells to go in there and the macrophages to start breaking down that areas of disordered tendon. That's what we're hoping for.
I feel like we're using a lot of words like maybe, hope, theoretically. What is the research here, Mark? Is there actually any research to support the things that you're injecting into people's shoulder like me?
There is some data showing that this is helpful. And again, it depends on the patient and the protocol that you're using. And the hard thing with PRP data is that people prepare PRP differently. So you don't exactly know what you're getting in the data and when you go see a clinician sometimes. But there's some really good studies out there focusing on chronic tendon pain, mostly around epicondylitis and plantar fasciitis. One study that comes to mind is people that have epicondylitis, which is tennis elbow or golfer's elbow. They compared PRP versus steroid, which has been a kind of standard treatment. And the improvements were lasting at 1 and 2 years versus the steroid, which symptoms tended to recur. So that's one indication. There's some new stuff coming out as well with PRP being used to treat plantar fasciitis, which I think is pretty exciting. And I've had some good success with that as well. So this is typically paired with something called a tenotomy sometimes, where you go in and actually fenestrate or poke some holes in that tendon and then inject the PRP in. There's also some data coming out using PRP for osteoarthritis. And this has mostly been focused around OA of the knee. And this is a little bit different protocol, but there's been some studies comparing PRP to standard treatments such as hyaluronic acid or steroid treatments that show reduced pain scores and potentially more lasting effects than the steroid or the hyaluronic acid.
So in general, basically the idea is that PRP is this idea of using the body's own mechanism for wound healing and applying it in a concentrated fashion to some sort of injury, whether it's tendinopathy, whether it's arthritis, whether it's tendon tear, any of those are potentially opportunities for wound healing to be improved.
Exactly.
So what about all this other stuff that people are using PRP for? Are you familiar at all with the facial plastic stuff, hair regeneration, the P and the O shot? I mean, it seems like everybody and their brother is using PRP at this point for something or another. They're trying to use it for everything. Any sense as to whether that's realistic or not?
There are a lot of expanding indications for this, and
expanding indication. I like that. That's good.
I haven't had a chance to really sit down and look at the literature surrounding, hair loss and the cosmetic treatments of PRP. I have heard some things as far as PRP being used for cosmetic purposes, but it's not something I'm really familiar with. So I'm going to defer on that for now.
Can I just borrow some extra PRP if you have some? Stick it on my head and see what happens.
Yeah, you bet. Yeah.
Sweet. So what's it like? So you're basically going in there, you're extracting plasma from somebody and somehow separating it out and then injecting it basically. What's the procedure actually entail?
So usually the procedure will involve an initial consultation where you're going to sit down and talk with your provider, either a sports medicine doc or someone who's hopefully doing quite a few of these, who can really talk you through not only what the risks and benefits of the procedure are, but can take a good look at what you have going on and decide if you're a good candidate for PRP. So, I mean, like any other treatment, this is right for some people, but it's not the cure-all, and it's certainly not right for everybody. And there's some people that aren't going to benefit from this, and, they may get steered in another direction. So after that, the patient usually comes back for a second visit to get the procedure done. And that visit typically takes about an hour. We draw your blood, initially about 60 cc's, and then we spin it down and end up with about 7 cc's of platelet-rich plasma over the course of 2 spins. We use a closed system in order to do this. There's all sorts of different systems on the market, and most of them we think have pretty good platelet concentrations, but the one we're using has been shown to have the highest platelet concentration. We're really looking for the gross number of platelets to be around 5 billion or so is what we're hoping for. And then following that, we use ultrasound typically to inject that into the patient. And that allows us to localize the area right where we want to put that PRP, whether it's into the joint or whether it's into a tendon, so we can see in real time where we're injecting that. Following the procedure, most people have a little bit of pain. Like I know, Mike, you were crying like a baby after this.
Dude, you crushed me. Totally crushed me.
That's fairly typical sometimes with the PRP, as it does release some of the neutrophils that can cause this inflammatory burning type of pain response, which typically gets better over the course of a couple hours. Usually over the first week or so, the patient actually has more pain than they initially did when they came in. And then the effects from PRP, we really expect to see down the road somewhere at the 8 to 10 to 12 week mark. And we follow things kind of slowly over time in combination with doing some physical therapy to hopefully get someone improved. So we've got a whole kind of rehabilitation protocol that we put people through, where you're starting with kind of really gentle motion initially, and then progressing slowly back to normal activity. But again, depends on what area you're treating and what that rehab protocol looks like.
Dude, I remember literally having to sit down in your waiting room because as I left the visit, I was feeling so lightheaded. I mean, granted, I was in the middle of the fast.
You hadn't eaten in 5 days.
Yeah. I know, it's my fault. But I felt really bad. It really freaking hurt. But it felt good after maybe 48 hours or something like that. Things kind of got back to normal.
Yeah, most patients are tougher than you, so I mean, people generally do pretty well.
I'm a giant wimp for sure. Yeah, I can't tolerate needles. I don't like the needles.
No, not atypical. So some pain pills after the procedure aren't unreasonable, and usually a brief period of immobilization to kind of let things calm down before you start in with some gentle motion. But pretty common to not really have a huge response right away, and definitely we look at the judgment of success being a couple months down the road.
So I had a pretty big tear in my rotator cuff, and I think both you and I were kind of a little hesitant to whether PRP would actually give me any benefit. And looking at it on ultrasound since then, it hasn't completely healed, but I am back to functioning fairly well. I'm back to using my arm overhead and doing some weightlifting, and I'm biking and I'm skiing and doing all those things. So I guess to some extent a success story. Whether that has to do with PRP or not is hard to say. Have you had some success and some failures with this on both sides? And maybe you could just give us an idea of what your personal experience is.
Yeah, certainly. I think, one of the places where I see a lot of success with this is in people with recalcitrant plantar fasciitis. And I've had some really great stories of people coming in who have had
Can
years.
you just tell us what recalcitrant
So,
plantar fasciitis?
people that have had plantar fasciitis, which I don't know if you've ever had it. It is so annoying. I've had it, and it's just so hard to get better. But I've had a couple people who have had plantar fasciitis that have had symptoms for years and have done physical therapy, and they've done splinting, and they've done massage and acupuncture, and they've done steroid injections, and to the point where it's really limiting their ability to get up and around. And the one that comes to mind was a woman in her 60s who came in, and she was planning a trip to Europe and wasn't able to walk because her plantar fasciitis was so bad. And so we did a tenotomy and a PRP on her foot, and the plantar fascia. And
I'm sorry, tenotomy.
Tenotomy. So yeah, we poked around in the plantar fascia with a needle to hopefully.
Oh, that's nice.
Yeah.
That's real considerate of you.
We did a posterior tibial nerve block on her, which really made the procedure painless. So she tolerated it really well. But then injected some PRP in that area and put her through the rehabilitation protocol. And at 2 months out, she came back in almost in tears because her symptoms were gone, and she was able to go to Europe and walk around, and she was just super excited. So I think, those are one of the success stories.
I see. So 60-year-old woman, you put a nerve block in her, but my shoulder, you didn't put a nerve block in.
No, I mean, I thought you would have been tougher, I guess. Turns out I was wrong on that one. Some other cases that have been successful of medial and lateral epicondylitis or tennis elbow and golfer's elbow, getting those better, as well as some partial thickness rotator cuff tears. And I think, kind of like you were saying, Mike, you got a pretty sizable tear there, and it's tough.
Tear. It's a giant tear, just like it's the biggest tear.
It's the biggest tear.
It's huge. Yeah.
The idea of getting that structurally to heal is challenging, but I think functionally, I mean, we worked out the other day and you put the hurt on me. So I think if that's any indication, functionally you're doing pretty well. But everyone is different and people respond to this differently. And I've certainly have some people who come back with no improvement and other people who feel great. And it's a matter of the patient's underlying pathology as well as their characteristics of what we're treating that can determine that.
I think it would be kind of interesting maybe to go back in and try this again, but try to put myself in more of an anabolic state before we take the plasma to see if maybe that has any different effect. I'm just curious. I was just thinking about this today, actually, before we recorded the podcast. And you and I haven't actually talked about this before, so I'm totally hitting you from left field on this one. But it makes sense to me that we're trying to, in some ways, not just get the platelets, but also probably get some of the products within the plasma. Maybe even there's some, I don't know, I dare say the word, like exosomes in the plasma they're actually extracting. But there's probably something going on there, some cell signaling that matters, right? So if you take, the cell signaling that would be occurring in a catabolic state, that is probably not going to be as advantageous as you would get from an anabolic state. At least that's what makes sense to me, considering we're looking at things like IGF and VEGF and things like that. So I don't know that anybody's ever talked about this before or ever suggested it, but it sort of makes sense physiologically.
It'd be interesting to see how your nutrition and nutritional status plays into recovery after PRP. And as far as I know, that work hasn't been done, but yeah, I agree. And the other thing that goes along with with your shoulder is that a lot of times this takes more than one treatment. We just did one treatment on you 6 months ago, but the data, at least in knee arthritis, is typically done in patients that get between 2 and 3 injections spaced out about 2 to 3 weeks. And we usually judge the need for a second treatment in tendon injuries based on how a person is doing at kind of that 6 to 8 week visit and follow-up visit, and decide if we're going to do another treatment at that point, depending on their initial response. So not unreasonable to consider another treatment at this point.
In the realm of regenerative medicine, what are other options other than PRP? Are there some other things out there that people are injecting or talking about injecting?
So the world of regenerative medicine is expanding rapidly, and it's pretty crazy the things that have come out just since I've been in practice in the last couple of years. So we're seeing all sorts of things as far as amniotic chorionic membrane allografting, where you actually take processed placental tissue and inject that with the idea that you're getting some of those growth factors and cellular signaling that you would get in PRP. And there's some products out there doing that. Lipoaspirates, who are using fat-derived, either fat to heal or fat-derived stem cells. And then the whole world of stem cells, either from a fat source or from a bone marrow source. And there's all sorts of new things coming out all the time, like exosomes is the most recent thing that I've heard of. So this is a world that's growing really rapidly. And in my estimation, I think, we're going to see a lot more growth in this area. And hopefully we'll start to see some good data so we can really decide which of these products is best for which person. And that's not really out there at this point. So I typically judge things based on their safety first and then their efficacy. And we're still even waiting for some of that data, I feel like, on some of these newer products that are coming out.
As far as we know, the PRP, relatively safe, with the exception of maybe very low risk of infection, correct?
Yeah, as far as we know, we're taking someone's own platelets, so the risk of disease transmission is non-existent. There is some risk anytime you do an injection, but that isn't typically different than if you're doing a steroid injection as well. But as far as we know, the platelet-rich plasma really has little to no side effects besides the post-procedural pain that goes with it.
So not everybody listening to this podcast can come see you necessarily, Mark. What would you recommend to them if they've got an orthopedic injury, be it a tendinopathy or a tendon tear, and they're interested in potentially getting PRP?
So I'd recommend that you check out someone in your area who does quite a few of these procedures, and also someone who's used to using ultrasound and musculoskeletal ultrasound to guide their procedures, because I do think that makes a really huge benefit and a huge difference when you're doing a procedure like this, that you really want to not only be able to evaluate the tissue and make the proper diagnosis, but that you're able to really guide your procedure and put that PRP exactly where you want it to go. And so ask around or find someone in your area who's doing quite a few of these and then go from there.
Thanks, Mark. That's really interesting. I was always wondering what that perp thing was that you injected into my shoulder, and it's nice to know that it wasn't just some weird dude with like glasses, like hiding from behind a tree or something.
Yeah, I'm glad you're doing well. Let's hopefully you keep improving.
Sweet. Should we go hit the gym?
Yeah. All right. Talk to you soon.
If you do want to see Dr. Goodman, though, go to wildhealthpodcast.com and click on the Be Our Patient tab, and we can set you up with an appointment with him. And a lot of the other things that they mentioned in this podcast, we actually do have other physicians on our team that specialize in these. Dr. Durham, our director of anti-aging, uses stem cells and exosomes quite often. Dr. Hall, our plastic surgeon, does the P and O shot and even PRP for facial and hair regeneration like they were talking about. Or in the right circumstances, we may discuss using peptides like BPC 157 or others that are just emerging that you may have heard about. But what's right for you is going to be potentially totally different than what's right for Mike. If you got an issue, though, go to the website, wildhealthpodcast.com, and set up a call with us, and we'll discuss. Maybe we can help, and maybe we can't, but we're happy to talk it through with you. And we'll definitely dive deeper into some of these other procedures on the podcast soon. Thanks for listening.
We hope you like listening to the podcast as much as we like making it. If you think it's valuable, share with somebody. Send to someone you think would really benefit, and leave us a 5-star review in iTunes. Those reviews really, really help us out. Find us on Facebook and follow us on Instagram at WildHealthMD. If you didn't like, well, why are you still listening? Email us and let us know what we can do better. But the best way you can thank us for our time is to leave a review and share. Until next time.